This is Stephanie Huff, and I am doing a camtasia on oxygen, specifically asthma. So this is exemplar 15.2 from your book, which is asthma. Just an overview, this is a chronic inflammatory disease. They will have recurrent episodes of wheezing, breathlessness, chest tightness, and coughing. Most attacks are relatively brief, but some will last longer with varying degrees of airway impairment daily, which means that they experience problems every day with this difficulty breathing. The airways are in a persistent state of inflammation, which causes these airways to narrow. Asthma early in life can lead to irreversible lung function later in life with permanent structural changes called airway remodeling. And these changes can lead to progressive or even permanent loss of lung function. So that's why it's really important to diagnose and treat these individuals early. Triggers are what causes an acute response in the body. An asthma attack is prolonged by the late phase response, which develops 4 to 12 hours after exposure to the trigger. So these are some of the triggers of asthma. You have allergens. Approximately 40% of all cases are going to be related to some type of allergic response, and this can be related to tree or weed pollen. Other allergens can be dust mites. Those are found usually in mattresses and pillowcases, which can be a problem. Other allergens will also include molds, animals, feathers, and cockroaches. There is also an exercise-induced asthma, and in that case they recommend using an inhaler 30 minutes before they exercise to try to prevent this from occurring. Some of your air pollutants could be cigarette smoke, wood smoke, the exhaust from vehicles, elevated ozone layers, sulfur dioxide, nitrogen oxide. All of these can induce asthma attacks. Some of your occupational factors, basically they go to work feeling pretty good, but then they experience gradual symptoms by the end of the day, and it's usually some kind of substance that they're being exposed to while they're at work. I worked with a lady that she worked on nights, and every time they would strip and re-wax the floors, she would have an asthma attack. And of course they always did it on nights because usually there was less traffic flow. And so she would always end up being one of our patients in the ER, and then would have to go home. Respiratory infections can be either viral or bacteria, and they can trigger an asthma attack. Some nose and sinus problems. Some patients have chronic problems like allergic rhinitis, nasal polyps, chronic inflammation of mucous membranes in the sinuses. Some of your drug and food additives can cause asthma attacks. Most people have a sensitivity to aspirin and NSAIDs that have asthma. Wheezing can develop within 2 hours of ingestion. Your sulfites and your monosodium glutamate, or MSG, is another common trigger, and this can be found in fruits, beer, and wine, and used extensively in salad bars to protect vegetables from oxidation. GERD is another trigger of asthma. That's just the gastroesophageal reflux disease. And then, of course, emotional stress can also be a trigger. An untreated attack can lead to limited expiratory flow, hypoxemia, as well as hyperventilation. Looking at the pathophysiology and etiology of asthma, inflammatory mediators are released. And this causes an activation of inflammatory cells, which include eosinophils, neutrophils, and lymphocytes. And you'll see eosinophils elevated along with IgE in people that have allergies and asthma. Bronchoconstriction also causes airway edema. It increases the work of breathing. Your triggers in asthma also cause bronchospasms, which makes breathing more difficult. Edema is usually caused by excessive fluid in the body tissues. You can also have trapped air that mixes with inhaled air, so they have an impaired gas exchange. Further patho, we talked about the inflammatory mediators being the cause in early phase response. So you have that vascular congestion, so that causes leads to edema formation. They will also have a production of thick, tenacious mucus, which is thick and sort of sticky. That also causes the airway to become more narrow. They will also have bronchial muscle spasms and then thickening of the airway walls. And you can see all of those are ways that are things that cause the airways to become smaller, so therefore it makes breathing in and out a lot more difficult. And that's what causes that wheezing sound. All right, so this is just a picture showing you how small their airways can be due to those muscle spasms or bronchial spasms. You can see the swollen mucus. You can also see the mucus in there as well, which further decreases the diameter of the airway. All right, so looking at causes or your etiology, we talked about allergies, exposure to aspirin and NSAIDs, other triggers which we have talked about. When they come in contact with the stimuli, that will result in a hyperresponsiveness, which is an exaggerated bronchoconstrictor response. Status asthmaticus is a severe, prolonged form of asthma that is very difficult to treat. Untreated asthma or asthma that does not respond to treatment is a medical emergency and can result in respiratory failure. So these people need to be helped quickly rather than later. All right, now we're going to look at some difference in the pediatric population. Normally their airway is more narrow than adults to begin with, and so this causes a greater increase in their airway resistance, and that is just the effort or force that's needed to move oxygen through the trachea to the lungs. The edema and swelling will further make the airways more narrow, and this causes them to breathe faster in an attempt to get more oxygen in. Usually children under 6 use their diaphragm to breathe. By the age of 6, they use their intercostal muscles more effectively, and the ribs are primarily cartilage at this stage. And they're also more flexible because they are made of cartilage. All right, when work of breathing is hard, you'll see retractions, and that's going to be sunken areas between the ribs. As oxygen consumption gets higher, in children generally their oxygen consumption is higher than that as an adult, and this is usually due to an increased metabolic demand for their bodies. And they also have a more rapid muscle fatigue, so they get tired a lot faster than an adults would. So in kids, usually kind of what they say is they go down fast, but you can get them back fast. And because of that, you really have to be paying close attention to kids so that you can get them treatment promptly. All right, and then this is just another picture just kind of showing you the difference in the size of the airways. And so you can see a normal bronchial tube versus one that's inflamed and has excessive mucus in there. So you can see how that really makes those airways quite small. All right, some of your risk factors for developing asthma. Genetic factors, usually it just kind of runs in the family. If your parents have asthma, then you're more likely to develop asthma as well. Common causes of asthma are going to be air pollutants, your allergens, which we talked about, chemicals in food, stress, and respiratory infections, early exposure to RSV, which is a respiratory syncytial virus that we'll talk about later. Also chlamydia, and usually that is the mom has chlamydia when they're born, and it was not caught and treated before the baby was vaginally delivered. Also, early exposure to the influenza virus, adenovirus, mycoplasmosis are all associated with the development of asthma. Obesity, mom that smokes, and preterm birth are also associated with the development of asthma. All right, so prevention is to avoid allergies and environmental triggers. So a lot of times they will do allergy testing to kind of see what their triggers may be so they can better stay away from them. Some things obviously they can't stay away from, like grass and trees and pollen, especially if they live in the South. We have lots of pollen. Also, things they need to do is to modify the home environment, like trying to help control dust. They do have air filtration systems that will help. So a lot of times the parents will install these in their homes. Remove carpets, because carpet does tend to hold lots of dust and dust mites, covering mattresses and pillows again because of the dust mites. Pet removal, a lot of times the pets and their dander are associated with asthma. They do have some animals that do not have the pet dander, like poodles, because they usually don't shed and they don't have as much. So a lot of times if somebody has asthma and they really want a dog, they can get certain types of dog breeds that do not have pet dander that are, as you say, hypoallergenic. Also, stuffed animals need to be removed from the bedrooms. These do harbor lots of dust and allergens as well. So looking at clinical manifestations, you'll see coughing, wheezing, shortness of breath. They'll have some chest tightness, tachypnea, so they'll be breathing faster, tachycardia, their heart rate's going to be faster. Usually asthma attacks tend to be abrupt in onset or insidious, which just means they gradually build up. The frequency and the severity will vary from person to person, and even at different times with the same person. When asthma attacks are severe, you may see them use some accessory muscles. You may also see retractions. If they are wheezing a lot of times you can hear audible wheezing just walking in their room, and you don't even have to use your stethoscope to be able to hear it. You also may have some distant breath sounds. I would caution you though, when you can't hear lung sounds, a lot of people just assume that they're clear because they don't hear anything, and that just means they're not moving air. I did have working in the ER, I had a girl that was not moving much air at all and couldn't really hear lung sounds, and so I had ordered a breathing treatment, and the respiratory therapist, who was not one of our better ones, came in and asked who had ordered the breathing treatment, and I told her I did, and she says, well, not wheezing, do you still want it? And I said, yes, I do. So she went and gave the breathing treatment, and then she came back and told me, she says, well, now they're wheezing. And I told her, I said, now they're moving air, so you can hear the wheezing. So anyway, so this girl ended up getting several more breathing treatments, ended up getting an hour-long treatment just to clear her lungs. So be cautious if you don't hear lung sounds on an asthmatic that is coming in with an asthma attack, that they may not have lung sounds at all because they're not moving any air. Some people will have a mild form of asthma while others experience symptoms daily. Usually they're very anxious and apprehensive, which you would be too if you couldn't get enough air in, enough oxygen in. It just sort of does give you a panic type feeling. There are different types of stridor that you may hear. An inspiratory stridor is usually related to a partial obstruction of the upper airway. Expiratory stridor or wheezing and or a croupy or low-pitched cough is usually related to an obstruction of the middle to lower trachea and central bronchus. So that's right there in the middle. Inspiratory and expiratory stridor is from a fixed obstruction in the larynx and subglottal space. Hoarseness is usually from an obstructed vocal cords. So in order to monitor the disease, there is a peak expiratory flow reading. Sometimes you'll see it in some books, and some people will call it a peak expiratory flow rate, but they both mean the same thing. But this will provide objective measurement of lung function. They also have small ones that can be purchased and used at home to help determine the severity of their asthma, which is related to their airway obstruction. And so readings are taken several times a day, and in reading these they use traffic colors, so that green is 80 to 100% of their personal best. This means their asthma is under good control. Yellow is 50 to 80% of their personal best, which means caution. They need some type of medication or treatment. Red is less than 50% of their personal best, and it means immediate need of a bronchodilator and further medical treatment if their peak expiratory flow reading does not immediately return to the yellow range after treatment with a bronchodilator. So once they use the treatment, if it doesn't go back down into that 50 to 80% range, they're probably going to have to go to the hospital. Alright, so asthma in kids, it is very frightening for not only the child but the parent, because the parent wants to help them and they feel like there's nothing they can do. Asthma does interrupt their sleep, their ability to concentrate in school and play, which further causes frustration. So usually they'll have a written asthma action plan, and that will involve the parents, the child, and the school teachers. And it's important to take medications in a timely manner without overdosing, and that's why they want to include the school teachers as well, or the school nurse. Some schools do have school nurses, and other schools, the school teacher will administer the medications for the students. So if we give these medications in a timely manner without overdosing, this will keep the asthma in better control. Secondhand smoke dangers also need to be addressed. So if the parent smokes, you want to provide smoking cessation information to the parent, because this does make the asthma worse. I know when I was doing some clinicals for my nurse practitioner, I was at a pediatric clinic working with one of the pediatricians, and he would get on to the parents about smoking because it made their asthma worse, and they would say, but I don't smoke inside, I only smoke outside. And he would ask them, well, when you come in, do you change your clothes and do you wash your hair before you pick your child up? And of course the answer is no. And so them smoking outside, I mean, it does help some, but then when it's still on their clothes and their hair, and they're picking their infant up or their kid up and holding them next to them, it sort of defeats the purpose. So a lot of people don't think about things like that. So that's another thing as far as educating parents about smoking. All right, looking at asthma in pregnancy. Um, Asthma will improve in about 1/3 of the women that get pregnant that have asthma. Another third, it pretty much maintains the same, doesn't get better or worse. And then the other third, it will actually worsen during their pregnancy. Asthma is linked to premature births as well as low weight births. It is also linked to hyperemesis gravidarum, so that is excessive nausea and vomiting in pregnancy, and a lot of times they'll have to come into an ER setting to get some IV fluids and some type of antiemetic to help with the vomiting. Sometimes they actually have to be admitted if we can't get it under control. It is also related to and linked to preeclampsia, which goes along with pregnancy-induced hypertension, which you'll learn about in future semesters when we talk about high-risk OB. Asthma is also linked to uterine hemorrhage, and usually that's after the child is born. And it's also linked to prenatal mortality. All right, you need to control the woman's asthma because even a mild asthma attack greatly affects the fetus, because you think that when the mom can't get oxygen, that baby's not getting oxygen either, and that baby's a lot smaller and needs a lot more oxygen, so that they're not without oxygen for extended periods of time that can cause defects when the baby is born. So if an asthma attack does occur, the treatment is going to be the same as it would be for a non-pregnant woman. The effects of the asthma drug pose a lesser effect on the fetus than an asthma attack would if you didn't treat it properly. They do need a multidisciplinary care, so they'll have their OB doctor, they may have their primary care physician as well as a pulmonologist. So that would be a physician that has expertise in lung disorders, and that's just to make sure that the mom is treated adequately for her asthma while she's pregnant. All right, so collaboration, respiratory therapist will be included. Like I said, your OB doctor, pulmonologist, primary care doctor, and then nurses are going to be involved because they will be taking care of the patient if they're in the hospital. There are different classifications of asthma. There's a great chart in your book on page 994, that's in volume 1, that shows more detail, and it also shows clinical therapies for each type and what type of medications and treatment they'll need. But you do have a mild intermittent, which they have daytime symptoms that are less than 2 times a week. Nighttime symptoms are no more than twice a month. And that's how mild intermittent asthma is classified. Mild persistent would be daytime symptoms that occur more than 2 times a week, but less than once a day. Their nighttime symptoms occur more than twice a month. Your moderate persistent, they will have daily symptoms and nighttime symptoms more than 1 time a month. And then you have severe persistent, which is basically continual symptoms throughout the day and night. All right, diagnostic test. We already talked about the peak expiratory flow rate or reading. Allergic asthma, that's just when they'll do a scratch or patch testing to see what their allergens are. They will also do IgE testing to determine allergies. Your CBC with diff is done if they suspect an infection is going on. ABGs are done for acid-base monitoring. You've got pulmonary function studies, which looks at the functions of the lung. Chest x-rays are used to, a lot of times you can see if there's any type of pneumonia that may be causing some issues. Your oxygen saturation monitoring, that's just your bedside pulse ox, and that will monitor their oxygen levels. And then you have a transcutaneous oxygen and carbon dioxide testing that can be done, and basically they're looking at the difference in oxygen and carbon dioxide that is in the body. Alright, pharmacologic therapy. These are used to prevent and control symptoms. They do use a stepwise approach to this. Your SABAs, that's your short-acting beta agonist. Those are also your bronchodilators. Then you have your MDIs, that's your metered dose inhalers. Your bronchodilators, remember these are your short-acting beta agonist. These are the ones that are most commonly used. They do relax smooth muscles of the airway. You have your adrenergic stimulants, anticholinergic agents, and your mexalxanthines. Alright, corticosteroids and NSAIDs are also used. Examples of this type would be the cromolyn sodium and the necrocromol. Your leukotriene modifiers, these are oral medications. You've got your montelukast and your zapirlukast. I do have another PowerPoint that I'm going to do a Camtasia on that is strictly for the medications and drugs that are used in asthma and COPD. So we're not going to go as much detail on this on these slides with the drugs. Alright, complementary and alternative therapy. Herbs, there are, you do have to be careful of some herbal remedies that patients take, and so you want to make sure that when you're asking them their medications that they're on, that you're also asking them about herbal remedies that they take as well, because some of them will actually interact with the other medications they're taking. An example would be atropa belladonna, which is a natural form of atropine, and ephedra. It's also called mahong, and it's an herb that contains ephedra, and these should not be used because they interact with their prescribed medications. And then because of the dangers that are associated with ephedra use, drugs containing the ephedra, most of them have been banned from the market in the United States. Some of your herbs that have been used with success include quercetin, grapeseed extract, and capsaicin. Herbal therapy does not mean that prescription medications are not needed, but a lot of times they'll use them in conjunction with their prescription medications to help better control their symptoms. Other things that can be done are biofeedback, yoga, breathing techniques. A lot of times they'll do deep breathing and relaxation techniques have been useful in asthma. Acupuncture has been used, as well as massage therapy. Alright, looking at the nursing process, the short-term goal is going to be to maintain oxygenation and a patent airway. Long-term goals are going to be to improve their ability to function, and that's just in their daily life. Also the ability to participate in their activities of daily living, as well as exercise, and then also to improve their whole quality of life. So assessment is the first phase of the nursing process. Health history, you want to make sure that you're asking them about their current symptoms, the history of the symptoms that they usually have. You also will talk to them about medications that they use, their controller medications that help control their asthma. What do they use as a rescue inhaler, if anything. A lot of this goes along with the acute care. Sometimes they have specific regimens that work better for them than other people. So getting this whole history from them will help in their treatment regimen. When you're looking at their physical exam, you're looking at their overall level of distress. Are they using any accessory muscles? Do they have retractions? Is there any stridor? You also are looking at their vital signs, their overall color, to see, that will tell you a lot about their oxygen status. So if they're starting to look a little blue around the nose and lips, or even in the fingers, then you know that their oxygen level is not good. You also want to look at the respiratory rate and the excursion. So basically you're looking how much their chest is moving with inspiration and expiration. You want to assess their lung sounds for wheezing. Do they have inspiratory, expiratory, or both? Usually the most common is expiratory, and usually inspiratory wheezing is classified as worse than expiratory, and if they have both, then you know that's the worst. You are also going to assess their apical heart rate. Remember, they do get tachycardia and tachypnea. You want to look at their position of your patient. Are they in a tripod position, so they're having to sit up and kind of lean over their legs, trying to get more oxygen in? You also want to look to see if they have any secretions, and if they do, are these secretions thin or thick? The thinner secretions are usually easier to get up than the thicker ones are. Your next step in the nursing process is diagnosis, and so these are some examples of your NANDA nursing diagnosis. So you've got ineffective breathing pattern, ineffective airway clearance, impaired gas exchange, activity intolerance, anxiety, and ineffective therapeutic regimen management. Planning is the next stage in the nursing process. And so you've got the client will experience decreased number and severity of exacerbations, require fewer unscheduled visits to primary care provider or emergency departments, reduce exposure to irritants that aggravate asthma control, and experience improved quality of life. And again, these are generic kind of things. You would have these more specific to your patient, and these need to be measurable. And so that's why they put generic ones here, just because this planning process will be different according to your patient. You would need to know what, like how many exacerbations they have a day, so that you would know what to decrease that number to, because you want it to be doable, but also measurable. When they're looking at improved quality of life, that's going to be, an example would be fewer days missed from work or school, and then just them having greater ease and comfort with breathing. Implementation is the next phase in the nursing process. Promoting airway clearance. You want to monitor their skin color, temperature, look at their level of consciousness. You want to assess their ABG results and their pulse oximeter readings. You want to place them in a Fowler, high Fowler, or orthopnic position. Your orthopnic position is basically the patient is sitting up with their head and arms supported on a bedside table. And all three of these positions help reduce the work of breathing and increase lung expansion. Like I said, you can always breathe better sitting up. You want to administer oxygen as ordered to keep those pulse oximetry readings elevated where they should be. Administer nebulizer treatments and humidification as ordered. And then increasing fluid intake will help keep those secretions thin so that they're easier to cough up. Another implementation, which is enhancing breathing patterns. You want to monitor their vital signs and laboratory results. You want to assist with their activities of daily living to help conserve energy and reduce fatigue. Making sure that you're scheduling rest periods between activities. This also will help preserve energy and reduce fatigue on your patient. And then medications that you will administer. This can include bronchodilators and anti-inflammatories. You want to observe for a desired response as well as possible side effects of the medications that you're giving. These meds are used to improve airway status and help facilitate breathing. Another implementation is helping relieve anxiety. You want to assess their level of anxiety and assist them in identifying previous coping skills. So basically, you can talk to them about what coping mechanisms have they used in the past that worked for them, and then you can help them through these coping mechanisms, and that will help the client to regain control and help reduce their anxiety. All right, you want to actively listen to their concerns. This does support a trust between you and the patient. You want to make sure that you're including your client in your care planning and decision making. That will increase their sense of control. Reducing excessive environmental stimuli will help promote rest. Supportive family members. A lot of times you'll want them to come and be with the client because that will help also reduce their anxiety. Of course, if they're not very supportive, then that's going to increase their anxiety. So you have to be aware of that fact before you start letting family members come in with the client. Also assisting them in using relaxation techniques. This could be like guided imagery where you're talking them through a scenario. So if you find out they really like the beach, or if you find out they like the mountains, or whatever they really like, then you can have them close their eyes and picture themselves relaxing on a beach, listening to the sound of the waves, and basically you're just describing things in as much detail as you can so that they get a good picture of it, and that will help them relax. Also doing muscle relaxation where you can just have them again lying in the bed and having their eyes closed and just talk them through relaxing each muscle in their body, and that will help. Also, some people do really well with meditation. Another implementation is promoting adherence to therapeutic regimen. You want to assess your client's level of understanding of asthma and their treatment regimen, and this will help clear up any misperceptions and areas that need clarification and additional teaching. So a lot of times you can start off by saying, tell me what you know about this, instead of saying, you know all about your asthma, right? Because then, of course, they're going to think that they're supposed to say yes, and then they may leave and be still confused. You also want to discuss the client's perceptions of their illness and its effect on their life. You want to assist the client and the significant others to identify any problems integrating treatment into their lifestyle. You want to assess their knowledge, understanding of their medications, because the more they know about their medications and understand why they're taking them, the more compliant they're going to be. You also want them to, as well as understanding their meds, you also want them to understand their triggers and how to avoid them. For example, like smoking or pets and things like that we talked about before. You want to provide verbal and written instructions. Usually the written instructions are given to reinforce verbal instructions, and so a lot of times we tell patients a lot of stuff in the hospital and they understand it, but then by the time they get home they may get confused, which is probably the same way that nursing students are in class. A lot of times you understand things in class, and then by the time you get home and start looking at your notes, then things start going a little bit confusing in your head. Alright, so providing education regarding activity intolerance. You want to teach them how to monitor their cardiopulmonary response to activity. So they're going to take their pulse and blood pressure. So you will need to teach them how to do that. You want to also teach them how to monitor and record their pulmonary expiratory function rate or reading. And so a lot of times they will do some peak flow rates, and so that they will do these before and after activities to kind of see where they are. You want to help the client assess the capacity to sustain activities and what activities might be appropriate for them to do. And that may differ according to your patient and how severe their asthma is. It also is going to depend on how active they've been in the past. And then we're going to need assessment for short-acting bronchodilators. So before activities and exercise, they will need to have these short-acting bronchodilators on board. All right, so continuance of providing education regarding activity intolerance. You also want to teach the client to space periods of rest and activity so that they don't get overly fatigued and short of breath. Again, assisting with their activities of daily living as needed, and then providing the appropriate referrals depending on what your patient's needs are. All right, evaluation is the last step in the nursing process. And so this is when you're evaluating what your goals and plans and implementation of your client was. And so this is when you're trying to see, did you meet those goals with your implementation. So maintains oxygen saturation greater than 90%, demonstrates proper use of inhalers, lists common triggers, strategies to avoid, listing symptoms requiring immediate notification of a primary provider. Also, the client responds appropriately to asthma flare-ups. They maintain optimal nutrition to promote their health. And then they describe appropriate follow-up care. All right, here's a question for you. You're providing care for a patient with recently diagnosed asthma. Which key points would you be sure to include in your teaching plan for this patient? Select all that apply. A. Avoid potential environmental triggers such as smoke. B. Use the inhaler 30 minutes before exercise to prevent bronchospasms. C. Be sure to get at least 8 hours of rest and sleep every night. D. Wash all bedding in cold water to reduce and destroy dust mites. And E. Avoid foods prepared with monosodium glutamate, which is MSG. So the appropriate answers are going to be A. Avoid potential environmental triggers such as smoke. B. Use the inhaler 30 minutes before exercise to prevent bronchospasms. C. Be sure to get at least 8 hours of rest and sleep every night. And E. Avoid foods prepared with monosodium glutamate, which is MSG. So D is the only one that is not appropriate, and that's because all bedding should be washed in hot water to reduce and destroy dust mites. Cold water does not do that. All right, and so that's the end of the asthma lecture. Again, I'm going to have a separate one for the medications that are used in asthma and COPD. If y'all have any questions and need any clarification, please let me know, or you can make an appointment for tutoring. Thank you.